So we are going to have the next and final session, which is an open forum. So I'd like to invite the expert panel to come up and sit at the podium. And there are a number of topics that I'd like to go over. And last year, we had a suggestion, and probably from medical professionals who are interested to provide better care to the patients with polycystic kidney disease. So this is something that is increasingly relevant because now we have a first and kind of a mechanistic treatment, and this drug, tolvaptan, is widely available. We need to learn how to use it wisely in the appropriate patients, how to deal with the side effects. And so for individual practicing nephrologists, they may not have the critical experience and they feel a bit helpless. And so I think there's a lot of effort in terms of trying to build PKD Clinic. So maybe groups of physicians who may have an interest in PKD, they can work together and then they can support patients better by being more knowledgeable, having access to some of the more advanced tools that are becoming widely available. Many of these we touch upon, such as kidney volume risk assessment, genetic testing, and then the actual experience of using the drug. So one of the questions that I'd like to kind of open to the expert panel is what are the essential elements that would make a PKD clinic workable and successful? I kind of put a few points as of my own thoughts, and to me, like having been involved with the Center in Innovative Management of PKD for the 4th year now, I think that having a dedicated team of people who are really truly interested in the disease and willing to learn about the disease, because we are all at different stages of knowledge, and then having the nurse coordinator, radiologists who can provide the supportive role, the tools that are needed to make the proper assessment, such as kidney volume based kind of assessment. And then it's critical to the success of running a clinic that look after patients with PKD. One thing I also learned is to establish a respectful relationship with your patients, and that especially tolvaptan treatment, we are not really in a clinical trial situation, but it's really for treatment, and there are different patients who experience different degree of the side effect, and we can basically negotiate what would be an acceptable treatment regimen. And for the smaller clinic, and to have access to maybe more experienced clinic for advice if needed, also very helpful. And also in our center, we were really lucky to have kind of support personnel that help us to navigate for the drug reimbursement, and also pharmacists and dietitians to help to advise patients. So those are my own thoughts, but I like to open up to the other colleagues, and especially we have a number of really top-notch experts of the world, like who look after lots of PKD patients and from the US, and so any kind of thoughts and discussions that we can cover this topic.
We'll just go down the line. So I started my PKD clinic, or we call it the Center for Polycystic Kidney Disease at Tufts, probably about 15 years ago, and there was no tolvaptan at that point. And what we did was to identify the other specialties in the institution that were critical to the care of patients with polycystic kidney disease, because PKD is a systemic illness. We're not just focused on the creatinine and the blood pressure. So access to hepatologists, neuro-interventional team, whether it's neurosurgeons or IR, genetic counseling, social work, dietitian, all the things that you mentioned, a psychologist or psychiatrist for support. We created a registry, a database, independent of our hospital medical record system. And then I've always had a close relationship with our local PKD patient group, which has, been willing to go and give talks, participate in meetings, and I think that's been fairly well received. We're able to offer access to research studies now in addition to tolvaptan, which I think is also a draw. So those are the things I think of. It's not just a kidney disease, it's a systemic disease. It also affects the whole family, right? So people want to know, very common question we get is, when do I test my kids? So we have a lot of discussion about that. Because the U.S. health insurance system is bizarre. Not like Canada, where you can get care even if you have a pre-existing condition. So refrain from politics.
It's kind of a difficult question. We do not have a structured PKD clinic in one place. We have kind of a virtual PKD clinic. And so what I can mention is really what is important in my practice for the PKD patients, and probably I will forget things, but I'll try. So one important thing is the group of nephrologists who are interested in PKD. In my center, we are 5 nephrologists that the main interest, in some cases is almost the only interest, in some cases is a main or predominant interest, 5 nephrologists. I think that's very important because each one of us has more or less specified commitments, like is one of them that is in charge of maintaining the clinical database and running clinical trial. Another one is more interested in issues related to polycystic liver disease and pain control. Another one is just pure clinical, that kind of sees just the patients, myself. So I think it's kind of good to have a group of people that can talk to each other and work together. I think that's very important. Second thing is we have 3 nephrology nurses that work on PKD. And this is something that we developed just about a little bit over a year ago, mainly related to tolvaptan. I think it's very difficult to run a tolvaptan program without having very significant help from the nurses. And I don't think we would be able to do that without them. So these 3 nurses take care of all, initially when educating the patients about tolvaptan in a lot of detail, taking care of helping with all the bureaucratic work that is related to insurance papers, getting the coverage for tolvaptan, taking care of arranging for all the monthly tests that are necessary, reviewing the tests when they come back, communicating the test to us. We do have to sign the orders, but it's very easy because it's just pushing the button, they do the work. I don't know how we would do that without this type of help. Then we have, because we do have research clinical trials, we have the study coordinators. They are very helpful. This may not be applicable to all the centers, but in the centers where there are clinical trials going on, I think they are very helpful, especially also because one of the coordinators works very close to Peter Harris and takes care of all the things that have to do with genetic testing. So I think that's really very important part of the team. Dietitian, that's one thing that we are trying to get, is a dietitian dedicated to PKD. We don't have that. We are pushing for that. We have two nephrology dietitians, but one is dialysis, so it doesn't help us very much, but the other one is a general nephrology dietitian. I think that's really very helpful, and we would like to have a dietitian that is just taking care of the PKD programs. Then the other thing which is very important in the links with other specialties. I think radiology comes first, and I think both diagnostic radiology and interventional radiology, we have two interventional radiologists that take care of all the foam sclerotherapy and interventions like this. And it's very good that we have always the same, because they are experts now, and I think they are always available. I think the availability of the team is critical. So you don't get an appointment for 2 weeks later, but you get it for the following day. I think that's really very important. Then we have a neuroradiologist who is particularly interested in PKD. And then in terms of other areas, other subspecialties, we have a hepatologist who is also very interested on polycystic kidney disease, 2 liver surgeons who are interested on polycystic liver disease. We have for chronic pain a couple of anesthesiologists in the pain clinic that also are dedicated to PKD, or not exclusively, of course, but they are specially interested, so we can, I think, is you create your own network, kind of a virtual network that you can do these things. We have a vascular neurologist who is part of the ISUIA program that is also interested on PKD. And then, of course, we have the PKD Center, which has a lot of research ongoing, and I think it's very good to have this to go along with the clinical work. So these are all the elements that I think make a good PKD center, and I think it takes a while to develop, and I think, but that would be the ideal, I think. And I'm sure I'm forgetting things, but.
Okay, so you guys have said it all. I don't know what I can add. I would just say I've built PKD clinics twice. I moved from one institution to another, and I would just encourage you, it takes time. Every place has its strengths, so you just look for what is strong at your place and try to, as you both said, have good relationships with the people who are going to help you out, so that when you need something emergently, you can call and it gets done. That's very important. And I would just say that for me, I feel that tolvaptan has completely kind of changed the support that I feel that I need. So I don't yet have a nurse coordinator or any of that, and I'm doing it all myself with sort of some help, but I think it really does change things, because the monitoring is so intense and there's a lot of stuff going on. So, I definitely feel like that is something that I could use. You just need to have procedures in place so that it doesn't become I don't want to say a burden, but it can eat up all of your time, which then takes away from time that you have to interact with patients, as opposed to doing paperwork and making sure people get their labs and all of that. So I do think that's important. And then I would just say that I've made a really big effort to reach out to the community, to our nephrologists out in the community who may not feel as comfortable doing some of this. In New York, you've been a great example in that regard. So, to let people know, I've gone around to the different practices and given talks about tolvaptan and whatever other things they want to hear about, and just making it clear that we're here to provide support if they need it, not necessarily that we're interested in taking patients, but just, that if they need something in particular, that they can call and say, I have this specific question, can you see this patient? Can you answer this question? And then we send them back so that there's no issue. And then in our center as well, we've kind of, I feel that if people are coming to a tertiary place, part of the reason they're coming is because they want to know what's cutting edge. So we have made a big investment also in doing clinical studies, and we have a basic science research program that, I don't know, for me, I love that combination. So feel like I can shed a different light when people ask a fundamental question if you understand the basic science. So for me, I enjoy that. It's been important, and I think it's good for patients as well. So I will.
Well, I can reiterate a few of the things that were already said. Coming from a basic science point of view, my appointment was in the Department of Biochemistry when I came to Kansas, and I later joined the growing PKD Research Center there. And so I think it's very important now to, if it's possible, to have that connection between the clinical side, the patients and the clinical studies and clinical trials with basic scientists who also have an interest in the fundamentals of the disease. We make a big effort at Kansas to try to interest and recruit people from the various basic science departments who are doing things there who they may not realize how closely related what they're doing might be to PKD. And so we try to get them interested and recruit them. And so I think it's quite helpful for both to have that back and forth between the basic scientists and the clinicians. They learn from the researchers, and the researchers actually benefit tremendously, as I did, by getting to know the clinicians on an almost day-to-day basis, meeting with them and hearing from them and sharing with them. So it gives a different perspective to the, the kind of basic research that many of us do. Often in basic science departments, the projects that individuals work on are they can see a connection between what they're doing and some disease state. Many of them are, see a connection between what they're doing in cancer research, for example, but that's about as far as it goes. And so being integrated into a center that has both clinical and basic actually helps to encourage the basic scientists to learn better what they're really doing. So as a part of what we do, we're being in Kansas City, we are close to the PKD Foundation, and so often we host groups that come over to learn more about what's going on in PKD. Maybe they don't know much at all and they want some very basic starter stuff, but other people want to know the cutting edge stuff. And so we have sessions that don't take long to put together because we find that the researchers are very eager to get involved. But basic labs with students and postdocs working on basic science projects, they like to put up a poster, have patients come around, talk to them, answer their questions, and it helps the patients and helps these trainees who are doing very basic stuff. It helps them to see the purpose of what they're doing. So it's really a two-way street. So just to conclude, if it's possible, at a PKD center, try to incorporate some basic researchers as well.
So I'm just going to talk from, I guess, the interventional radiology perspective. I mean, I'm sure, like most people here, we're sort of resource-strained, long waiting lists for everything else, and trying to carve a little piece to get somewhat investigational procedure done can be difficult. So I really think that the collaboration with the nephrology service with Dr. Pei, and Dr. Pei was very instrumental in this, I think is vital. And Dr. Pei had sort of multiple discussions, I remember, with the division head of interventional radiology at the start to make sure that we do get the resources needed. Because you know, I think when you come to set up, especially if you want to set up the sclerotherapy portion of this, there might be a little bit of skepticism because it is investigational. There isn't a lot of data, and you know, waiting lists are long. So this collaboration, I think, has been essential and worked really well for us. The other thing that I think is worked well is writing down on the radiology side kind of a standardized protocol for these patients, so that, you know, if I do it or if one of my colleagues does it or whatever, they all get more or less the same standardized treatment that's sort of agreed with and developed with nephro. So that would be kind of my 2 cents.
I think the main message I hear from all the experts is that as if you're a parent, you know the saying, it takes a village to raise a child. And I would say it takes a community to look after optimally PKD patients. And this kind of community can be built in a different clinic setting depending on the local availability. Big center obviously have a lot of resources, but small center can still start and build on the different areas that can eventually provide optimal care to patients.